All right, everyone, welcome to our April staff meeting. We have several presenters that will be speaking during this meeting. We'll go ahead and get started. If you want to get paid, make sure that your camera is on. Make sure you are on mute also. So for our care commitment, I'd like to start off. In case you don't know, today is Administrative Professionals Day. So I'd like to recognize all of our secretaries, Monica, Deanne, Ryan and Nick, for making sure that our unit is operating at an optimal level. They have strong communication, organizational, and technical skills, and we would struggle without them. So thank you for everything that you guys have done and continue to do, and happy Administrative Professionals Day. Some kudos, and it's always great hearing or seeing what the patients write on here. So several of them that stood out. One of them, Christine, on night shift, always providing exceptional care and kindness to both me and my mom. She always went extra to ensure my mom and I were comfortable and taken care of, treated my mom like a person, not a patient. She should be one of our top nurse trainers to demonstrate real patient care. So great job with that, Christine. Yasmin entering the room every single time with a smile and being attentive with every request that the patient made. Jackie offering a shower and volunteering to assist, and she went out of her way to make sure that these issues were addressed. So great job, you guys. Couple more on the next slide. Megan, not enough lines on this paper, exemplifies what it means when you say, I am Methodist. Her service and care to my mom was extraordinary, and she deserves your picture on the wall of recognizing excellence. Even having Savannah and Kayla, one of our new residents, who they've been exceptional in their desire to both care for and assist the patient. They walk with them and to help them get back on their feet. Nurses like Ashley S., making it easier for them to have peace. This was the first time I couldn't stay with my husband due to work, and I know that he had a nurse that he can joke with. She helped him log into the school website and encouraged him. So great job with that, Ashley. Our April birthdays. Happy birthday to Alvin, Friday, Rael, Renju, Sue, Christina Like, Helen, Trin, and Celine. And some anniversaries. Maria Avila, Zadok, Sumya. I'm sorry, Rael, it's my fault. Monica and Emily. So great job on having between 2 and 12 years of service. We also like to recognize Curtis and Kaylee being awarded the Rose Award. And these go out to our ancillary staff for demonstrating just great patient care, service, and excellence to all of our patients and their families. So congratulations to you both. Great job with that. Next up, we have Nicole with patient experience.
Hey everyone, it's Nicole. If we have not met, just so y'all know, I'm one of our patient experience consultants here at Methodist. I've been working with Mansfield for about 5 years now, and I know y'all have probably a few of you seen me up on the unit before today. But just wanted to go over a little bit of patient experience stuff that's going on with A5. So first of all, you can see all this beautiful green y'all have. So currently you're at a rank of 87 with a top box of 80.5%. That means 80.5% of your patients that you all are taking care of think that we are a 9 or a 10 or better. So that just is shows how incredible of the care that you all are providing. Honestly, it'd be even higher than that if it wasn't for a little bit of a rough start to the year in October, November, but you can see that y'all have maintained these high 90s since December, which is absolutely fantastic. The only thing I really kind of wanted to point out, and just for you all to think about and for us to dive a little bit deeper into, is that communication with nurses domain. Can you go ahead and go to the next slide for me, if you don't mind? Perfect. So this communication with nurses domain is quite a bit lower than where we were sitting at last year. So something I just want you all to keep in mind. You'll notice that there's two different sections on there. There are questions that have this like gray undertone and then the ones with the white. Those are two different types of questions that we ask our patients. So the gray one are our CAPS questions, and those are questions that are measuring frequency. So when we ask if nurses treat you with courtesy and respect, we're not asking necessarily how well we're doing it. They're asking how often are we doing it. And so, you as a care team all working together, 9 out of 10 times, we may be treating our patients with courtesy and respect. But if one person out of that 10 is not, that's going to taint our patient's perception. And they might start thinking, when they can't answer always, it's now sometimes or usually instead of always treating me with courtesy and respect. And then the second section, that nurses overall, the questions underneath those are asking how well we are doing it. So the answer choices for those questions are very good, good, fair, poor, very poor, as opposed to the always, usually, sometimes, never with the communication with nurses. So just something I wanted to point out, especially since we have seen that dip. And so I kind of wanted to open the floor for a minute and just see if anyone had any thoughts on what may have changed, why that may be the case.
I think it's the type of patients that we've been getting because our floor has been really heavy for a while now. And so if it's just one person that takes it or like a few people take it, because we'll have like a few not so easy patients take care at the same time, and we divvy them up, but they're just so high maintenance.
Yeah, no, that's fair.
And taking care of them is like really hard. And so I feel like recently too, like it's a lot of family members as well that we've been dealing with. So I mean, I would expect that it'd be okay for us to have like ups and downs with it, depending on like our patient population.
Yeah, I think that's a very fair point. Thank you for sharing that. Anyone else have any thoughts?
Nicole, piggybacking off of Vivian, I think our normal, easy, like I say normal patient, like alert and oriented walkie-talkie patients, we're no longer getting since CDU is thriving and, stealing those patients for us. So we're getting patients that are here for like 2-3 months that are very difficult discharges and difficult in general. So
yeah, no, that's great insight, y'all. Thanks. One other thing to keep in mind too with the courtesy and respect is, I don't know about when I think of courtesy and respect, I often think of like, am I being nice to you? Am I speaking kindly? Like those kind of things. When in reality, most of the time, that's not actually it. It's usually stuff like, did they go in and flip the lights on me? Did they treat me in a way that I would want to be treated? Did they, shake my hand? Did they acknowledge me as the patient in the room instead of my family in the room? Those types of things that are very small. And as long as we are intentional with it, we're able to do a little bit better. So that's all I wanted to share on that. Sol, can you go to the next slide for me?
Can you protect my cup?
So this is something, I'm not going to go deep into this, but this is a key driver report. And so what this means is these are the things that are most highly correlated with our patients giving us a 9 or a 10. So this is actually coming from our data from last fiscal year, but you'll notice that the nurses treat with courtesy and respect is the top key driver. So that is one of the most important things that we can do, which is also part of the reason why I wanted to show attention to that on the previous slide, because if it's not something we're focusing on, there's a good chance that we will start to see that 9 or 10 slip. After that, staff work together to care for you and doctors listen carefully to you are kind of the next important ones. Go ahead to the next slide for me. So just like breaking this out, y'all don't need to know all of this, but I just want to kind of show a little bit better how important that is. These blue circles and red circles, those numbers show our average top box score. So if for 9 to 10, so if our patients give us a top box response for nurses treat you with courtesy and respect, 87, our average top box score for rate the hospital 0 to 10 is 87.3 versus if we miss the mark on just that one specific thing, only 22.6% of our patients would give us that 9 or a 10. So just very briefly going over that, if we don't hit nurses treat courtesy and respect or staff working together to care for you, or the doctors listen carefully to you, go down that path, there is not really a way for us to recover and get back into that high top box score for rate the hospital 0 to 10. So I just like to point that out. And then next slide. Okay, there's a lot on this slide. So we don't need to read all this word for word, but this is coming from a resource that Press Ganey gives us. And Press Ganey is the organization that does our surveying for us. And just some of the ideas for improving that nurses treat with courtesy and respect, I wanted to share because they're, like I said, they're super easy things to implement. It's not like we're talking about changing your whole nursing practice or anything like that. So stuff like knocking before entering the patient's room, asking permission before performing any procedures, touching, all that stuff, ensuring that patients are covered appropriately during examinations or procedures. Not from y'all's unit, but we actually just had a comment today come in that was a very long comment from a patient talking about how they were very embarrassed because they were not covered up properly and they felt like they were on show for everybody because their door was also left open. And just simple things like that. So of course that patient doesn't feel like we treated them with courtesy and respect. Make sure your body language is matching the words you use, maintaining eye contact, shaking patients' hands when appropriate, and then commit to sit too. That's a big one and a pretty easy one to implement. When you have that ability to sit next to them and talk to them instead of hovering over their bed, really just puts you at the same level with them and makes it a lot easier to have that conversation and it makes them a lot more comfortable and helps build that trust. Make sure we're responding, following through on any of the things we say, manage up. A lot of these things on here are simple. I just wanted y'all to have this resource so we don't need to go through all of it, but make sure you're listening, avoid interrupting the patient, truly listening and understanding their needs, not the needs that we assume they have. Warm smile, greeting the patient using their name, all those easy things, just being intentional about them, I think are going to be important. Okay, that was my very quick deep dive of patient experience, specifically for nurses courtesy question. Anybody have any questions or any other thoughts that they want to share? I just wanted to give some easy tidbits for y'all to improve upon. But other than that, y'all scores are fantastic and y'all are doing an incredible job. So please, please, please keep up the awesome work.
All right, thank you, Nicole.
Of course, happy to help. If y'all at any point need anything from me, want me to come spend time on the unit, whatever that may be, please just reach out and I'm happy to help and be a resource.
All right, will do. Thanks, Nicole.
All right, thanks y'all.
And to find in conclusion with this, I know Vivian made some good points and Rachel too, and our patient population is changing. It's different after becoming a level 2 trauma. And then the barriers that we're seeing, just like anytime we go to a restaurant or get our nails done, whatever it may be, it's those little things that people do that can change the impact or change the course of action while we're there too. And so we want to make sure that we do our best to make sure that we do the best for our patients, but also there's situations that it is challenging and we can't please everyone. I understand that too. And if we need to sit and talk with the patients, myself or Crystal, or get us involved, we are happy to advocate for you guys to listen and make sure that, we have a good outcome. Next up, either Ka or Carlos. I'm not sure if you guys are on the call. No, we can come back to them later.
Oh, Carlos on here.
Yeah, I spoke with him a few minutes ago. If not, we can come back to him here shortly, and we will move on to Sarah. All right.
Okay, go ahead and go to the next slide. All right. Saul had reached out to me earlier this week about suicide patients and contraband to be removed. So, long time ago, it used to be in with our policy and procedures. There used to be a list that you can see, but that's no longer the case. It's built in within Epic. So, whenever you click on safe environment, you either click yes or no, but you can see the row information. So I just widen it up bigger, but this is all within Epic. So to the left side of that red box are basic items that may be used while under direct supervision, which is, blush, body lotion, body powder, and so on. Everything that's in that red square is contraband, and that should be removed from the patient's room. Next slide.
Sarah, I had a question.
Yes.
It might be on the next slide or this slide. As far as silverware
So that's going to be in the policy.
policy.
And if you go to the next slide, how you get to the hospital policies are you go to the HR hub and then you click the HR policies and you can click on the Mansfield browse, or you can just hit the search box. Go to the next slide. And when you go in the search box and type in suicide, then you might click on the assessment and management of a suicidal patient. And I don't have the whole picture of the policy there because you need to know how to go to policies and read that, because it is your responsibility as a nurse to know these things. But in that policy, it does tell you about their plasticware and finger foods and so on, and step by step on what you need to do. And also in the blue, you see sitter observation checklist. If you go to the next slide, as nurses too, you need to print this out for your patient care technicians or whoever is going to be sitting for your patient. This is part of the medical record. You put a sticker on it. It goes on the patient's chart when it's done. But it starts at 7 a.m. That day and ends at 6:59 the next day. It's good for 24 hours. So they should get a new sheet on the next day. And it's got to be filled out every 15 minutes. And there's little codes on what you do. An initial, the back page shows you how to correctly chart. We go through this very thoroughly with all the new hires whenever we went system-wide new hire orientation. So any new PCTs and sitters that we got starting February of last year, we go through this and do little scenarios and explain what they need to do when they're a sitter. Next slide. And then again, with the policies and knowing where they're at and how to locate it, these are policies that have updated for the month of March. Because every 3 years, policies get reviewed and updated, and these are some of the policies that have been updated. Next slide. Therapeutic phlebotomy, we've been seeing this a lot here lately, but it is something that our PIC team can do because with therapeutic phlebotomy, someone's got to stay with that patient during the whole time of the procedure, and also they need to engage IV to drain that blood out. The that right that you that for information.
Hey, Sarah, you're kind of cutting out. Sarah, it's kind of, we can't really hear you that well. It's cutting out.
Okay, hold on.
All right.
Let me take off my headphones. Hold on.
Okay.
All right, can you hear me?
Yes.
All right, so I just took off my headphones, so hopefully that'll help. Therapeutic phlebotomy. The PIC team will assist with this. Someone needs to be in the room with the patient during the procedure, and also it has to have a 16 gauge IV needle to do the procedure. If you want to learn more about it so you understand what's been going on with your patient with it, we do have policies on that, and also Mosby Skills Nursing. Next slide. And then this is something that came up. Just in case you get any trauma admits, which you shouldn't, a lot of the trauma patients should go to B4, and then the overflow would go to B5. But you never know, if we have a lot of trauma patients, they might come to your area. But if you ever get a trauma admission, this is part of our trauma practice guidelines, and this is something that needs to be charted on admission. So if you ever see audit C alcohol screening tool under your order history, because once the order is acknowledged, it disappears, you have to go to your flow sheets and type in audit C and answer the alcohol questions. Next slide. And then recently, this went live earlier this month with PCT documentation update. To the right is your old, and to the left is the old way of charting, and to your right is the new way of charting. And there's a QR code that you can scan, and it'll bring up these 3 pictures here showing you how to document urine color, urine appearances, your stool color and appearances, and when you need to notify the nurse with certain things. And we'll go over this some more during our PCT skills day coming up. Next slide. And then again, thank you for those who've already signed up for PCT Skills Day. We still have some more that need to go sign up. And again, you only need to sign up if you were hired. Anyone that was hired October 1st of 2025 until now, you do not need to attend. Everyone else needs to attend. Next slide. And then Atrazil is a new wound care product that you'll start seeing a lot more. This little signage here will be located at the head of the bed, like where the speech therapy will put their information if your patient has Atrazil. We just cannot remove that Atrazil dressing. It starts out as powder, and then it turns into a gel, and it turns into the color of the patient's wound as well. But if you have any questions or concerns about it, then contact the wound care nurse. The only thing that we will be doing is changing that outside dressing, because you'll have the Atrazil powder and then a non-adhesive gauze and then some ACE bandage or something, or Curlex roll. Next slide. And then trauma hours, we have this coming up. May 27th is a Zoom, and you can do it from home. It's just 1 hour long, and this will give you 1 CE of trauma hours. Next slide. Also, this is our April of 2026 free CEs from health.edu. Next slide. And then Nurses Week is coming up on May 11th. So here's all the fun stuff that will be happening during the week. Next slide. And then again, I encourage y'all to check out our acute care website, because we will be getting a new product next month. We're going to get new vital sign machines. And this is a video of what it all entails. PCTs, you'll be signing into the vital sign machine by scanning your badge. I think they're trying to get that working. If not, then you'll have to sign in like using your computer ID number. And then there's a scanner to scan the patient armband. And you'll do your vitals, and this will upload into Epic. So this is going to be coming next month. So if I were y'all, watch this video so you can see what's coming, and Probably going to need some super users for day shift and night shift for this. So anyone who wants to earn some level and points, reach out to me. And that's it.
All right, thank you, Sarah.
You're welcome.
All right, coming up next, we have Carlos here from our VAT team.
Hi, I'm Carlos. If those of you that don't know my name, they know our number for sure. The PIC team, we are here during day shift hours.
Hey, man,
These slides are put together by Ka and Ty and myself. So we're trying to let every department know exactly what we do and how we're gonna try to proceed with everything. We're here during day shift hours. We would like you to contact us promptly whenever you have any issues with your vascular access devices. Instead of waiting towards the very end of the shift, because it does get very hectic towards the end. Everybody's wanting to pack up and be ready to go, but it's a lot of documentation that we have to do and also prep for the next day. They've also posted where we would like to avoid the repeated calls, because during some of these sterile procedures, we can't answer the phone like right in the middle of it to risk contamination. So it has a caller ID. We'll be able to return all of the phone calls or chat messages and all of that. We'll give you a thumbs up once we get done or return your phone call. But also, if it has been an extended amount of time, please reach back out to us, because we will put you on the list. We do put you on the list, and we don't want to forget about anybody, because their treatment stops when they don't have a way to get their medications. But also try to cluster the calls. We've worked with our management to try to see if we can cluster the calls through the CTLs or charges, so that we weren't boomeranging all over the hospital. I wanted to emphasize the fact that we do not perform stat IVs. Now, I know there are some situations like certain infusions, like blood and things like that. Make sure that you guys are assessing your IV before you even send down for the blood, because once you get it up here and then the IV is leaking or it's going bad, now we could be in the middle of a procedure, and then now you're against the clock to try to get that blood back going. So please assess your lines before you go get the blood to infuse. This is something new. I don't know if Carl or Ty has grabbed any of you yet, but management has requested that one nurse stay during the entire procedure for a timeout and to witness the sterility to prevent CLABSI. That includes the primary nurse or CTL or the charge. So that's something new that may get you a little behind or what have you, but they want to try to have another witness to make sure that these lines aren't contaminated upon insertion. This is for when patients return to the hospital with a PICC line that's already inserted. You would assess with the chest X-ray. You can place the order under the ID partner who's associated with the patient or the hospitalist. You can go ahead and check for blood return if your flush is easy, and wait for the chest X-ray to result, and possibly go ahead and perform the dressing change if it's outside of date. If it's inside of date, make sure you document the next dressing change date on your PICC line assessment. And people misdocument PICC lines and midlines all the time, so they want you to look close. It may look purple and everything, but look at the hub. The hub will be either purple or white. The white is a midline, but a lot of midlines get charted as a PICC line, and it throws us off. And when we get a chest X-ray, there's no line there, so they received a chest X-ray for no reason. So there's just one extra helpful thing that you can do is just actually visualize the line to make everybody chart on the exact line that they actually do have. And usually this is supposed to get done in the ED, but if they're a direct admit, you may end up having to do these chest X-ray orders and dressing change if possible. Let's see. Care and maintenance. The lines are to be flushed once per shift. Use the entire flush, and then use the Curos caps. Scrub the hub before you use it. The PIV dressing changes, and this is something that people are slowly realizing that they do have to do, because we've been documenting the 96 hours that's when the next dressing change for the PIV should be done, and that's to keep from getting an infection. Okay, guys. Let's see. Cap the end of your tubing whenever you're exchanging the medications. Don't leave the cap open to air or the hub open to air. We've been given the responsibility to either verge or throw away the medicines if it's open to air. And I know it may be open for just a few seconds or what have you, but it's been times where we would get called into the room to place a line and the medication is open to air. So without any hesitation, regardless of what medication it is or how expensive it is, it goes right into the trash. So, and that's for patient safety. There's germs and bacteria, they're coughing, or the door going open and closed. So we want to make sure we're not connecting that right back to the patient. So this is something new also. You can draw from any vascular access device. That also includes PIVs. You have to treat it like it's a midline or a PICC line. You have to do a waste. And if you do not waste, you're going to get a diluted specimen, and they're going to get those results put into their chart. They're going to get more labs requested and possibly even have to transfuse the patient. So make sure that if you pull from a line that does have good blood return, to avoid having to stick these patients with lab and everything, make sure that you do the waste before you use that for a specimen. Also, if they have multiple infusions, do not add a new line on the same side with the PICC arm. So no blood pressure cuffs, no needle sticks, anything on that side. So list it as a restricted extremity and document that it's for PICC line or midlines that the arm is restricted for.
Carlos, I do have a question. Whenever they're drawing blood from the PICC line, should they be changing the caps every time?
It's not necessary, because the that's part of our weekly maintenance. But if it is giving you some resistance or some hesitance, a fresh one wouldn't hurt either. And we're still going to change it again when that 1 week dressing change is due.
Okay, thank you.
So the therapeutic phlebotomy, if you have not done that, please reach out to us so that we can try to get in to help you and to perform that, because it's a straight needle. It's a big needle. I think it's a 16 gauge. Even Met have a very difficult time with actually performing this procedure. So if you guys need any help, please call us whenever you have one. That's when you come from huddle and you see that that's due for that patient that day, let us know in advance so that we can try to work you in and set a time where we can actually get that done. Metaports, A4 is the experts, but also call us if y'all need some help with a Metaport, and call us if the PICC or midline is not working. And they're still ironing out whether, oh, okay, the cath flow, whether it can be put in by any RN or just us. But if you haven't done it, just call us and we can walk you through it or show you how to do it. No, that is it. So I appreciate you guys for letting me into your meeting. But we're approachable, we're friendly. You know, we may be short, but we're kind of like that because sometimes we get calls back to back to back during the sterile procedure, and it is frustrating because the patients don't know what's going on. They don't know that we're responsible for the entire hospital, and the phone is just blaring right there next to them during this procedure that they're scared to have anyway. So, but I thank y'all for letting me be a part of you guys' meeting. Thank you.
Yeah, thanks, man. Thank you. All right, next up we have Shauna with our Rise Skill of the Month.
Hey everybody, for April, our Rise Skill of the Month is SBAR, situation, background assessment, request or recommendation. In the nursing field, we all kind of know what this is. Everyone uses it. We're taught this from the beginning, but this is the tool that can be used by any department, any person. Maybe our secretary is calling maintenance to let them know about something that's broken on our unit or something that needs to be repaired. They can use SBAR so they can make sure that the appropriate and accurate information gets relayed to those maintenance people. So this is a tool that everyone can use for safety. What is the situation, the patient or the project? Communicate the importance of the information. Make sure you include any barriers or concerns that you have. Provide your assessment of the situation, and then present your request or recommendation. Did you close the loop? Sometimes once you get to the bottom of your SBAR, you may have to circle back and say, hey, did we get the answer to what I originally kind of asked for? So make sure you close that loop. It's an intentional tool that that's used to build trust and decrease risk and to promote patient safety. I think over the last several days, the unit has been very difficult, and we've used this tool to communicate those things. I know I see it when I was the charge nurse in the charge report. Secretaries use this in their report, and I think that just helps maintain safety all the way around. Thank y'all.
Thank you, Shauna. Next up, we have a couple presentations. Christina Like, are you on there?
I'm here.
All right.
I'm just going to talk about my fall. I had a patient, she's pseudo seizures, telepsych. She had been acting up, shift change. We were in and out of her room pretty often. I also had another impulsive patient that was getting up, dragging his Foley around. And then we had a code blue all at the same time. I was doing compressions when I heard the code fall. I guess whoever was coming up to the code blue saw her there. So I went back and we did all the things, and she ended up saying she was sorry. But basically, she really needed a sitter. She had a sitter the day before, and she got a sitter after the fall. I guess I could have skipped the code blue and stayed and watched her, but I wasn't thinking about it at the time. But she's okay. And I guess I just need to watch those patients more closely.
Thanks, Christina. I know that was a pretty eventful shift that night, and there's a lot going on, and I know we spoke about it. You did a really good job making sure that a lot of fall precautions were in place. It's just one of those unfortunate things. Okay.
Thank you.
Thanks,
And
Christina.
to be fair, we were tag teaming her too. So it's like people were always watching her. It just happened to be in that moment.
Mhm.
So just speaking up for Christina.
Yeah,
Thanks,
no,
Vivian.
thanks, Vivian. No, I know. I think on one of the in the shift reports, Tanner, I wrote on there that I did a really good job doing those things, and we're not going to never have a fall. They're going to happen, but I think how you guys handled everything and did everything you could. It's just, one of those things that it just happened, even with all the interventions in place. So thank you
Yeah.
guys for helping her out and, standing by the room and doing everything possible.
Thank you, everyone.
Mhm.
So, one question. Is it practical for us to even dream of one day having beds that go all the way to the floor? Because this patient was intentionally trying to climb out of bed the whole shift.
I know some of the beds, they go pretty low. I'm not sure if that's standard for all these striker beds. And I'm not sure if she had the normal bed or a special type of like a bariatric bed for her. Um, but majority do go all the way down to the ground for the most part, except I think the bariatric ones.
I think they make some beds that actually go down to the floor. Like
Yeah,
that's
literally.
specifically
Oh,
made
to
for
the
those
floor.
patients.
You know, I know we just got these beds, and maybe eventually one day, it's almost like we may get one of those that they are actually on the floor, but then it'll be kind of difficult for all the nurses having to, scoot all the way down, but we can bring the bed up, obviously. Maybe one day, Jackie, we can get one of those type of beds that if they do happen to fall, it's just a little roll over and they sustain no injury at all.
We need those beds for everyone.
Yeah. All right, next up we have Christine.
Hey guys. Um, so my situation is way different from Christina. So this happened during shift change. Um, the patient just came back from MRI and like literally just came back from MRI and she went to the bathroom. She was alert oriented times 4. So she went to the bathroom by herself. The family is in the room as well. And then, according to her, she just felt like she wasn't herself while standing up. And so she just sat on the floor in the bathroom and she called her son to help her. So the son came inside the bathroom and helped her sit on the reclining chair. And then she called. So Uju, the tech at that night, um, went to check on her and she said that she had a fall in the bathroom. So that patient came in for like they were thinking that she might have a seizure at work because she passed out. And so yeah, we did a fall protocol, like we did a stat CD, and thankfully it came all back normal. Nothing happened, no bleeding. But I think like since before coming to the hospital, like her diagnosis wasn't even a seizure, but she had a fall before coming to the hospital that makes her high risk for fall. So what could have we've done better is when she arrived from MRI, we should have went to her and check on her, make sure she got everything she needs. And even though she's alert oriented times 4 and she's up ambulatory, she's still like kind of really a high risk. So somebody should be with her. But thankfully, nothing happened to her. So, yeah, that's it.
All right, thank you for sharing. One thing that we've mentioned to the radiology department, who oversees the transport team, is whenever they bring a patient back, applying the bed alarm or letting staff know when they have arrived so they can help us out too with that. So I think that could have been something that could have helped in that moment too. Okay. Thanks, Christine. Next up
Thank
we
you.
have next up we have Rania.
Hey y'all. I sadly had my first fall last week, and we put this patient on the bedside commode. She was really weak, she wanted to go to the bathroom, so we placed her on the bedside commode. And she told us that she can't use the bathroom while we're there. So me and the tech step out, and we're both waiting outside the door, but it's the most busiest time of the shift. It was med pass time, and me and the tech both got super caught up in the amount of calls we were getting at the time. So we unfortunately both walked away from the door and we answered those calls. And once the patient that was on the bedside, well, whenever we placed her on the bedside commode, we continuously told her, call us when you're done. Don't try and get up. Please don't get up. And she understood, but we should have never trusted her. And when she called, we went in and she was sitting on the floor and she told us that she tried to wipe herself and she fell and hit her head on the sink. So something me and the tech could have done is, working out a plan between each other, like, hey, I'll stay near the door, maybe watch her through the window and make sure she doesn't get up. I think walking away was our mistake. So yeah,
Gotcha.
that's what
No,
we would do differently.
gotcha. No, I think that's a good thing, but also I think I did a good job staying by the door first. I know sometimes we get patients that want the privacy. We all stood outside, which is really good. But I think you made a good point of try and have somebody there if possible. I know it was, like you said, a busy time during the shift with the med pass. So, okay. Thank you, Rania. Next up, we have Ashley.
Hi guys. So I'm gonna talk about my fall from March. It was my 20-year-old patient. She was post-op day 5, I think, at this time. She was young, but she was always complaining of pain. She also hadn't gotten out of the bed since she had surgery. So our goals for the day were to get up at least to the chair. And she also hadn't had a bowel movement since before surgery. So in the morning, my student and I, we tried to get her up to the chair with her walker. She stood up, but her pain was kind of high. So we just sat her back down and said, we'll try again later. Gave her some pain meds. I also gave her some milk and mag. And then maybe about 40 minutes later, 40 to an hour, I can't really remember the time. She said she needed to have a bowel movement. We had told her we would do bedpan, but she was very insistent on going to the bathroom. So we compromised and said, okay, we'll do a bedside commode. It was right next to the bed too. So we were just doing a stand and pivot. We had gait belt, socks, walker, all the things, stood her up. She was fine. Pivoted to the bedside commode. She was there for like a minute, said she couldn't go. So my student and I, we stood up with her together. And as soon as we pivoted, she kind of gave out and went backwards. And I just kind of went with her. And so, yeah, that was my fault. But I mean, we had everything in place. We were advocating for our patient, trying to make sure that she was still moving. And I feel like even if I had Sean with me that day or something, like she was 300 pounds, so we probably wouldn't be able to hold her up anyways. So just one of those things with her.
All right. Thank you, Ashley. Like this is another example of one of those things where you have everything in place for your patient, socks, gait belt, right next to the bed, and pretty heavy patient. Thank you, Ashley. All right, next up we have a Hinneman.
I have a question
Yes.
in regards to Ashley's patient.
Mm-hmm.
So initially we had a communication that we needed to have our patients, whether physical therapy or OT came to evaluate the patient or not, we need to have the patient out of the bed, and which is a requirement post-surgery. So I'm wondering, and I'm thrown into a confusion, like, should we still wait for them to come and do such evaluate for us to know the safety and how best the patient can move? Or what's your take or in regards to Ashley's patient?
Mhm.
Thank you.
Yeah, with that patient, PT did come by and assess the patient, and they were with the two-person assist. And so her and her student were in there with the patient. She did fine. There were some other issues with the patient. I think some developmental delays, and I think how she was, she, may have played a part in that as far as, not doing her part, going to the bed. So they did what they're supposed to do. And unfortunately, I think the patient had other thoughts in mind and, she went down. But they did follow the PT recommendations with a two-person assist using the gait belt, uh, the yellow socks on, everything. So I think if they follow that protocol, I think really well. Now, if you have other patients that need to get up and out of bed, I know that's one of the things that we want to do with our patients. I think using your best judgment and assessing the patient, if they're able to stand up or not, educating them. So if they want to get up, use the bedside commode, offering the bedpan. If not, of course, using those interventions in place to make sure that you prevent any kind of falls with the patients. So either, again, assess patient properly. If PT has a note, following those recommendations, but you or the tech, y'all are in there a lot. So you kind of have an idea of what the patient is capable of doing and maybe what they're not capable of doing also. All right, next up we have Ehneman.
Okay, my phone happened through a code. We had a code in 25. We all went, and then I left to go check the patients around. I told some of our colleagues that I was going to go around to check and make sure patients were safe. And then I went to my room and I saw my papa in bed. I just checked. I made sure the bed alarm was on. And then 17 called for his pain med. As I was going, I saw Christina enter the room. Christine, the tech. She entered the room to go check. So as I was giving 17 his payment, the bed alarm went off. So we all ran there. Tana, the doctor was there, the nurse practitioner, everybody was there. So we got in. Initially he said he was trying to go so
Hold on, Henneman. It's kind of breaking up. Henneman?
then go maybe see what was happening.
This is Christina. Also, I had been in that room several times to explain to the patient, because he kept trying to get up, explain to the patient that he didn't need to get up, that he had a condom cath, because he kept saying he needed to go pee. And I kept explaining to him that he had a condom cath and that he didn't need to get up. I showed him the condom cath and show him where his urine was going. And so that was probably like the third or fourth time I had been in there. So after the fourth time, I left out. Of course, his bed alarm and everything was on. And so I went into another patient and started cleaning another patient. And so that's in between that time, that's where the fall came, and he being in room 17 as well. So he just kind of fell in between the times we were both in other rooms.
Yeah, gotcha. Okay. Kind of like a previous one where everyone was getting pulled to different things. Okay.
Yes, yes.
Gotcha. Okay, thanks for sharing. Henneman, we couldn't hear you for a little bit.
Can you hear me now?
Yes.
Okay, so the doctor came. Tana did the code 4. The doctor did the assessment. I did my assessment after him. We went for CT. It all came out negative, and he apologized to Tana that he was sorry. Only Tana. He apologized to just Tana. Well, he's fine, and we're all good.
Okay. All right. Thank you for sharing, Henneman. I mentioned earlier, falls are going to happen. There's no unit that's going to have no falls at all. And so these things are just learning experiences. We talk about it, everybody chimes in, has any feedback, and then that's it. It's not a punitive thing. So, you might find yourself in one of these situations and you think, oh, this happened to so and so, let me do this differently. And that's what we do. We talk about them, we learn, and that's it. So thank you everyone for sharing.
Yeah, can I just follow up too? I don't know if you had mentioned it. Just remember that when we have those code blues or RRTs going on, remember that we have our code team and we have that buddy system in plan, right? And so in place. And so whenever whoever shows up first, you're part of that code team. So everybody else, I know that we want to be there. We want to see what's going on. We want to have helping hands, but we are not needed. Okay. We need to go back to the unit, protect our patients that, those that are in the code, and just kind of be rounding on them and just being hyper aware and making sure that those patients are safe as well.
Yeah, it's a good point. Thanks, Crystal. All right, next up, we have Crystal with our updates.
It's me. Hello, y'all. So Sarah talked, just some updates, just something that I just want to briefly talk about. Sarah already talked about the Audit C screening on admission. I sent you all an email about it this past week too. Please review your emails and just make sure that we're doing what we're supposed to be doing. Again, I don't know if we're ever going to see this, but one thing that I was saying in the email was, if your patient came in for a fall, like maybe just do it. It doesn't hurt to document extra, especially when it's only like 3-4 questions, if you remember to do so. Okay. Diabetes management. The only thing I really want to say about this is just a reminder, just because Pat was coming by and I was asking her how everything was going. She says we're doing a great job. She gave kudos actually to Chi for creating an incredible note on the entire process of treating her patient with high blood sugar, then low blood sugar, those kind of things, following up with physician. But as a reminder, always give that long-acting insulin. We never hold this. Okay. And so that was just her only reminder that we wanted just to pass on to the team. The next thing I wanted to mention, which I have mentioned before, is clinical access. If you've never heard those words, here it is again. You should have heard it before. This is our access to telemetry, and you as a nurse going in and checking. Our policy states, that you only have to check it once a shift. I feel like as a nurse, if your patient's on telemetry, we should be checking this every 4 hours. Just because I'm only bringing this back to our attention. I did learn there are several nurses that didn't know it even existed. So please make sure you have access and clinical access. If you don't, send us an email, we can get that for you. But for me, we've had a couple instances recently where patients have had where either Telly doesn't report it to you, or we're not looking at it, and then Telly's writing verges or what have you. But I just wanted to give an example that if something were to happen to your patient and you're in a courtroom and they ask you, you have access to your patient's Telly monitoring, do you not? You say, yes, I do. And they say, what is this clinical access? You either say what it is, or B, you say, I don't know what that is. And they're going to say, well, actually, you were given access to it on this day. I've seen you access it maybe this many times. They're going to go through that. And they're going to say, your patient had an event on this day, but I don't see that you looked into clinical access. And they're going to have you right there. You're just going to be, up a creek without a paddle. And so please make sure that you're looking in clinical access, you're monitoring your patient's telemetry in there, just so that you can make sure that, because sometimes Tele documents your rhythms, but maybe it's not accurate. Maybe that's not what you see. We need to be documenting real time what you see that's in there. Anybody have questions about clinical access? It's very important that we're getting in there. Okay. HIPAA. I talked about this last staff I was going to say menu meeting, and we're still leaving all of our assignment sheets around the unit and just open to everybody to read. Please be super mindful of this and make sure that we are flipping over our information. We're grabbing those cover sheets up at the desk, of your information that you can put on your clipboards or whatever. We're protecting patients' information. When you're walking away from computers, we're turning those screens off, turning your computers around, those kind of things, just being very aware of that. I know that there is I don't even know what it's a stand, and it has all the assignment in it and the doctor's phone numbers and all of that. That gets brought onto the tabletop a lot of the time, and it gets turned to the outside to where everybody can see the assignment sheet. The folder is open all the time. So just please, please, please make sure that we are protecting our patients' information. Okay. The hospital is sometimes, well, not really. It's like not a safe place all the time, especially since we're moving into trauma 2. There's people looking for people. We are housed next to a locked unit. We just kind of want to just be proactive and be aware of everything that's going on, and just protecting patients' information. Okay. So please make sure that you guys are putting those assignment sheets in the Shred-it when you're done with them and not leaving them out willy-nilly. PCTs, I just want to give you guys an update on your bath logs. There are still several PCTs sometimes who do not fill out the bath log. I do expect you guys to be doing this. We need to get an accurate reading on how many baths are getting done. But I will say this, that patients are not complaining that they're not clean anymore. So I really do appreciate you all completing baths and changing linens, even nursing helping as well. As far as percentages, patients, day shift, we're completing about 61%, and this is based off of documentation that you're giving me, okay, with the bath log. And night shift, you guys are completing 39%, okay? And then as for CHG bathing, this is a topic that is not just in general with our unit. It was a generalized conversation with everybody on multiple units, is that making sure that when we give a CHG bath, that we are bathing our patients with soap and water first. Then you use your CHG wipes or the soap, however you guys want to do that, and a full linen change. Okay, where you don't just wipe patients down with CHG wipes and tell them, all right, have a good day. That's not a full CHG cleanse proper way to do it. It is soap and water, CHG wipes, and then your linen is always changed as well. Any questions? Thank you.
Thank you, Crystal. Next up, some updates. We have some new staff members starting on night shift this week, a PRN and a full-time PCT. We have a PRN on May 4th and a full-time on May 18th off for night shift. For day shift, we have a full-time PCT starting on May the 4th. We are currently looking to hire a full-time night nurse. If you know anyone, let us know. We've hired some people that have been referred in the past. So if you have anybody, make sure you let us know. Capital, we bought a new phone for $717, 6 new linen carts, which we are exchanging all of them out. So it's a little bit over $1,500 for so far, past few weeks. Last day to buy any kind of sweatshirts or jackets is tomorrow. So email me if you want to purchase one. Unit etiquette, make sure that we are throwing away our items, or putting away our items too. Any trash that's around us, make sure phones are going to the proper place. If you are checking out any chargers, make sure that they go back to where they belong also. Want to make sure that everything's tidy and clean. And physician chairs also, make sure that they stay in the physician room. And one thing for next week, on April 29th, from 10 p.m. to 12 a.m., there will be an electrical shutdown. Same thing happened last year, I think in the fall. So only the gray outlets will work in the entire A side. The shower lights in the room will work, and the quiet time lights will be on in the hallway, and the ice and coffee machine, they will be on also. What will not work is anything plugged into the red outlet. Red will not work. The med rooms, the ice machines will not work. The sink and the toilet lights in the patient rooms will not work either. The tube station will be down. The Omnicell pharmacy is currently looking at that, and I think that's why they delayed this electrical shutdown until 10 p.m. after MedPass. But I will know more from pharmacy in case we need something stat or something PRN and what that will look like. Badge reader, I'm supposed to receive an update sometime this week. More information will be going out to you guys. I wanted just to give y'all a heads up. We had a meeting on Monday about this. They're thinking 2 hours, but I think it will be less. But they're giving themselves 2 hours in case something happens. It takes a while for everything to reboot. It may actually be 30 to 45 minutes, which I think last time it wasn't that long. So more information will be sent out. So anyone working on 429, last time everything went smooth. I think everything went well. We don't have any patients really on anything that needs to be connected at all times. So we'll make sure that the IV pumps are charged or plugged into a gray outlet. If the bed doesn't move up and down, we just move it to a gray outlet. But we'll give out more information about this to our charge nurses and the staff that are working that evening too. For our goals so far, our 3 goals, we're still currently red in 2 of them, but we have made progress. I think we were at 55.4 last time, 56.4. We're a little bit below 2 percentage points to get to minimum. Explaining daily plan of care, we went up a percentage point also, so we're only 1.1 percentage points away from the minimum. Patient experience, 87th percentile. I think from today, may have gone to 85th percentile. Huge change, huge increase over the past couple weeks, kind of like what Nicole explained earlier. So compared to last month and this month, we had 71 surveys. We have 87. We were at 78th percentile. We were up 87th. This is from Monday. Again, I believe it's 85th percentile. One thing that we talked about and what Nicole said was nurses treating with courtesy and respect to our patients. We were at 76.4, 78.4. So just by going up 2 percentage points, we saw an increase in our score also. But I want to say you guys have done a phenomenal job with all this. It takes a team to ensure that, we're doing what's best for our patients. We are there for each other. This new backlog that was implemented a little over a month ago, when we round with our patients and receive feedback, hygiene care, something that's being done. And so everyone plays a role in this. And at the end of the year, this is what helps everyone with their merit increase. So it's this patient experience percentile, and it's these 2 things also. So if these 2 things are low, the percentage drops a little bit, and the merit increase isn't as much. If we're able to meet challenge in all these, we get a perfect rating on this overall domain, which increases the overall percentage. So you guys are doing a phenomenal job. Great job with that. Any questions about anything? Any feedback on something? We do have Nurses or Hospital Week, the 2nd week of May. There's a lot of things that the hospital is doing for you guys, and we'll make sure that we do something special for all of our staff also, okay? Something that you need more information on, we forgot to mention, let us know, myself or Crystal. If not, thank you for everyone for being on this meeting, and we'll kick off to UBC.